Thank you very much, Sister Zamzam. Dr. Yirgu, so you have been in the leadership position in one of the biggest hospitals in Ethiopia when the pandemic hit and to this date. So how was it like? What is your experience with regard to deploying your professionals to fight the pandemic, especially in the earliest times? Logistics, such things. So how was your experience?
Good morning to all of you. There were a couple of issues as we embarked on the COVID era. Now, the first issue is that this is something quite unknown. In fact, nobody knew exactly what is coming, when it's going to come. In fact, when the first case was detected in the country, which was March 13 on a Friday, we were called for a meeting to orient our staffs about what COVID is all about and all the preparations that we need to deploy in order to handle such issue. So that was the level of preparedness, even at the country level. Okay, we're not prepared, the least that I can say. Now, once we knew that COVID is coming, then what is the next step to combat with the situation? So we had a series of brainstorming sessions within the management, and then we realized that the existing management structure within the college is not good enough to handle such an emergency. Rather, we need to formulate an emergency operation center, EOC, which operates along the whole College of Health Science. As you know, College of Health Science has got 5 major units for our schools: School of Medicine, School of Pharmacy, School of Nursing and Midwifery, School of Public Health, and then definitely the largest hospital, which is Tukurambasa or Black Lion Hospital. So all the 5 elements of the college have to be able to move in tandem. And then we have to use all the local knowledge and resources available. So we established the EOC. This is around March 16. And then we had our first meeting on March 18. Remember, this is within 5 days of detection of the first case. And then the next step that we did was we did an environmental scan, an assessment of what do we have, what is missing. This is in terms of PPE, in terms of surveillance, in terms of treatment facilities. Between March 13 up until today, we have added only 5 ventilators. All the ventilators that we are having are the already existing ventilators. Okay, again, this talks loud about our level of preparedness. Now we are having quite massive number of cases. We have got a huge number of patients that require mechanical ventilation. However, the resources are still quite limited. And then the next step that we did was we did a comprehensive planning. The EOC had almost 12 units within itself on the various aspects of preparedness, including case detection, including surge capacity, including infection prevention, psychosocial support, pharmaceuticals and logistics, communication, etc. So all the 12 units move along a predefined line, yet we meet again to see whether we are delivering what we have intended to deliver. Now, that planning exercise has been quite useful because by then, even we don't have a national plan. So we had to go to the Federal Ministry of Health in the presence of the state minister and the directors. We showed what our plan looks like and the resources that it may take in order to handle COVID at a tertiary facility like ours. It has been quite an input to the ministry by then. Now, however, despite a detailed planning exercise and describing what it takes in terms of PPE, what it takes in terms of medications, in terms of a surge of ICU capacity, conditions are literally the same. We have not got the support that we essentially requested. Now, following the first case, as already stated, during April, there is quite a restriction of movement in different regions of the country. And then access to services were quite limited. We're doing a daily count of a number of patients that are visiting. And by the third week of April, in fact, the daily patient load along the whole, this includes obstetric care and other services, were curtailed to 50% of our capacity. This is because there was a predominant fear in the population, fear amongst health workers. There is quite a restriction of movement. Definitely, patients who were supposed to come to us were not literally coming. And that was really a disturbing moment because on one hand, we have to fight COVID, its consequences. But on the other hand, which is equally important, or even more important than COVID, was maintaining essential services, okay, like oncology service. There is nowhere else, maternity service. Even in Addis, we have heard of women who are delivering at home and women dying even at home. So that was really quite a scary moment. And then that was like a moment of awakening when FMOH made a decision that Tukur Ambassa is going to continue to serve as a non-COVID center. And this specific designation of being a COVID and a non-COVID center came around with all its consequences. Then what happened? Between March to August, cases were trickling. We are identifying patients who are COVID positive after they have been admitted to the hospital. And then the surgery cancellation rate goes up to almost 70%. The reason being, patient is coming, they get tested. And, by then, the turnaround time for COVID tests were on average 5 days. So by the time the result is available, patient is scheduled, then, physicians know that these are COVID positive cases. And then the cancellation rate really rose quite high. In fact, one day, I remember amongst 8 pediatric cases that were scheduled, 6 were positive and they had to be canceled. So then we have to reorient the way we do our business. What do we need to do? We need to start an in-house testing. So Tukur Ambassa started in-house COVID testing on its own without any assistance from any other entity. In fact, there was a hurdle. The hurdle was because you have to get approved by EPHI to be a testing center, we're told, okay, this is a site good enough for testing, but you do the test only that we provide you, okay? They collect all the tests, it goes to EPHI, and then EPHI ration the testing across the city. We said, no, we are not going to do that. Even if you are, the authority which gives permission, we need the testing capacity to do testing for our patients only. Okay, that really reduced the turnaround time for COVID tests to less than 24 hours. Then in August, when we do the daily count, we had about 24 cases of COVID patients with other comorbidities, which cannot be handled by any so-called COVID designated centers. The centers were telling us, okay, we can treat the COVID, but we cannot treat the malignancy or the additional comorbidity because we don't have the specialty, we don't have the medication, etc. Okay, so it doesn't matter, what kills a person. Once a patient is dead, it doesn't matter whether this is COVID or whether this is a malignancy. Okay, so when we had these 24 cases which stayed within hospital with a COVID positive test result, staying for about 18 days on average. Then we make a decision. And we went to the ministry, said now it's time that we integrate COVID services within our facility and do an integrated COVID and non-COVID services. The point of this is, maybe Dr. Malet will elaborate on this. We had one very interesting, very challenging experience of a woman who is COVID positive, morbidly obese, with severe preeclampsia, which needs intubation and mechanical ventilation. And then this woman cannot be transported from her bed to the OR because the fear was if for any reason the endotracheal tube gets dislodged, then it would be exceedingly difficult to reintubate this woman. And then she had to be operated on her bed. Unfortunately, the lady passed away after a few days, yet the neonate survived. Okay, so that led us into the second phase of our task of reintegrating or integrating COVID and non-COVID services. We have already availed now 2 floors for COVID services within the hospital. So what is the output of all this exercise? We have produced a number of teaching materials. That have printed materials as well as audiovisual aids. We have, in fact, started sanitizer production prior to the COVID era. That was like literally a manual process. Now we have a semi-automated process of sanitizer production, which produces about 3,000 liters of sanitizers per day. But we are moving forward to a fully automated production, which will materialize in a very few days, totally automated, and with a production capacity of about 5,000 liters, 50,000 liters per day. And this would enable us not only to supply the hospital, but also other facilities around us and also avail it on commercial basis. We have trained other facilities like the Army. The whole management of the Armed Forces Hospital came to us. We showed them how the EOC operates, and they have had an in-person and first-hand experience so that they establish the same within the Armed Forces premises. We have 39 bulletins. This is a 44 weeks exactly of COVID. We have 39 bulletins because, as you know, all of the informations that we use for whatever purposes are information that we gather from the outside world. we don't have a local information. So we started right from the very start, producing our own bulletins. If you are interested, we can avail it also online or provide it to ESOG to see what is happening locally, what is happening in terms of COVID as well as non-COVID services. We have some research outputs. Already there are about 4 publications in peer-reviewed journals. Definitely we are going to produce more research outputs based on local evidences. What is the challenge? The challenge is still we need to reorient more resources to combat and contain and mitigate the effect of COVID. There are shortages. I've been crying like for 4 or 5 months now. Nobody is listening. There is no gloves. There is no gloves even in the market. Okay, the gloves that we are having are hoarded by merchants who have fixed the price, who have fixed the minimum quantity that you need to procure. Okay, this has to be seriously addressed by the ministry so that PPE is properly supplied to facilities like ours. If you look at the positivity rate, again, this is a challenge that came with that designation of being a COVID and a non-COVID center. If you look at a COVID center, the majority of the health workers are protected. If you look at the number of positive rates in the COVID centers, there are very few. I've got nearly 120 staffs who are COVID positive, okay? Because we could not provide the necessary PPE to our health workers. So the Ministry of Health has to seriously think about this. Now, the other challenge is the issue of incentives, okay? I understand why a facility is designated as a COVID center and someone else is designated as a non-COVID center. But no patient will come with a clear label on the forehead saying this is a COVID patient, okay? So if you sit at the emergency, you are likely to encounter a patient who is COVID positive having some other comorbidity. If you sit in the antenatal OPD, then you would have a patient who is COVID positive and coming also for antenatal care, okay? So because of this designation, I think Ministry of Health can defend itself, but none of the incentives are coming to our health workers, okay? Now, there is a difference between federally managed hospitals and regionally managed hospitals. As you are all aware, for example, the Addis Ababa City administration has exempted its health workers from not paying income taxes, okay? Whereas our health workers being managed at a federal level are not getting any one of the incentives, okay? So we are serving the same population. We are working in the same geographically defined space. However, the treatment of health workers is entirely different, both at the federal level as well as regional level. Even within federal facilities, there are some differences. I will not talk about the details from here. I think the other challenge which we have come to realize is that probably initially we thought, COVID is something that would go away like in a week, 2 weeks time, but we are not really accustomed to the fact that we are going to live with COVID. I don't know how long, but in terms of preparation, okay, in terms of, now we see in the immediate recent past, our positivity rate was in the range of 9 to 10%, yes? But our positivity rate currently is standing at around 14%, 15%. The number of patients in the severe category are increasing. our capacity, our preparedness is still quite limited. Okay, one of the area where capacity is limited is in the ambulance transfer and communication. If you have got a critically sick patient, you want to transfer this to one of the COVID centers, it's virtually difficult. It's virtually difficult because we have, these long vehicles with no facility inside. So what you have is a nurse, probably an oxygen cylinder, and then a driver who runs around. Okay, none of our ambulances are fitted to do life support. So we need ambulances that provide comprehensive or advanced as well as basic life support. The issue of PPE, I cannot emphasize it enough because this is really quite a shortage that we are having. We need to have access to personal protection equipment. I think these are the issues from my side. Thank you.
Thank you very much again.